Hello, good afternoon, everyone. Professor Charlie Teo already here. Hello, Charlie.
Hey, Cecil, how are you?
How are you? Everything is good?
I'm very good.
Thank you.
Did you want me to give the talk, or did you want me to just, are you going to play the video?
You can directly give your talk if you want to, but if you already have a video, we can play it for you.
No, I'll give my talk directly if you don't mind, but you know, you've only given me 15 minutes. So if you don't mind just butting in when I start, maybe give me 5 minutes warning before the end, and
okay,
and then 2 minutes warning, just so I don't go over time.
Okay. It'll be nice if we can directly hear from you.
Okay, good.
Actually 10 minutes, but maybe for you special because you are a special guest. Everything is okay in Sydney, Charlie. You are locked down
Yes,
now.
except I'm missing all my friends. You know, I used to travel almost every second or third week, as you know. And so now that we haven't been traveling for almost 2 years, it's I'm finding life a little bit boring.
Yeah. And Sydney locked down right now, right?
Sydney's in lockdown. We're getting more of the Delta variants, and the numbers are increasing. So people are becoming even more paranoid, and the hospitals are starting to fill up now as well, and younger people are dying. So it's not as bad as the rest of the world, but it's not too bad. It's not good.
Okay, similar situation in Indonesia. We have lockdown also extended until 9, August 9. Okay,
it's hard.
Yeah, we will start in 5 minutes maybe. We wait another participant.
Do you mind if I just try and share my screen now just to make sure it works? I'll just make sure it works.
Okay, please.
Okay, can you see that?
Yes, good. Do you have video on your slide?
Yeah, I have videos.
Please try it.
Okay. Maybe I don't have videos. Let me look. I did try and cut it down, so because of the time. No, maybe I don't have. No, I don't have videos. No, it's good.
Okay, good.
Yep. Yeah, I did have videos, but it just takes too much time.
Okay. Dr. Agung Budi, ada di here. Hello, Dr. Agung.
Yes, I'm here. Hello, Mas.
Okay. Do you want to give your speech directly or you have a recorded video?
I have recorded already, but if you don't mind, I can give you directly.
Yes, we are afraid that direct speech will extend the time, but if you can stick in 10 minutes, we will allow you to give direct speech.
Okay, thank you.
Okay, Professor Rida, ready here? Not
I'm
yet.
ready to start when you give it the word.
Okay, Charlie, we will start maybe in 4 minutes.
Okay.
Dr. Nyoman Golden, sudah bergabung? Belum. Dr. Andi Ikhwan? Ini co-host saya ini, co-moderator, Dr. Siapa ini?
Dr. Bayu, dok.
Dr. Bayu, oke, Dr. Bayu. Dr. Bayu itu Dr. Charlie mau kasih speak langsung, nanti mungkin kurang 5 menit diberitahu ya. Kan 15 menit, tapi 10 menit kan seharusnya. Tapi mungkin dia dikasih diskusinya enggak di belakang kan diskusinya ya.
Ya, di belakang diskusinya, dok.
15 atau 10 menit ya? Saya kemarin kasih tahu 15.
15 menit, dok. 15 menit.
Nanti kalau sudah 10 menit diberitahu dia ya.
Siap, dok.
Oke, Dr. Bayu. Oke. Prof. Rida belum masuk ya?
Belum.
Prof. Rida, Dr. Nyoman Golden juga belum ya?
Prof. Rida ada pre-recordingnya, dokter.
Oke, pre-recordingnya ya. Dr. Nyoman Golden juga ada?
Belum masuk, dok.
Ada pre-recordingnya?
Oh iya, dokter ada.
Pre-recordingnya juga ada, Dr. Nyoman Golden. Oke, Dr. Agung juga ada, tapi dia mau kasih langsung.
Oh iya, bisa, dok. Siap.
Oke. Saya kemarin mau kirim pre-recording, tapi kata Dr. Rohadi suruh ngomong langsung aja. Oke. Kita bisa mulai jam berapa ini? Tolong diberitahu.
Lagi 3 menit, dokter.
3 menit ya.
Ya, masih ada peserta di kuliah plenary utama, dokter.
Oke. Jadi we're waiting for the participant that's still in plenary lecture.
Yeah,
Maybe.
I thought so. I thought you might be running a little bit over time.
Yes.
All right, doc. I think before we started, I would like to introduce you first.
Okay, thank you.
Today, for the first satellite session of school-based oncology, we will be led by Dr. Rahadian Indarto Susilo, PhD neurosurgeon. He is a lecturer and functional medical staff, Department of Neurosurgery in Faculty of Medicine, Airlangga University in Surabaya. He is graduated from neurosurgery specialist from Universitas Airlangga too. And now he is consultant neurosurgeon in neuro-oncology. And he's completed his PhD on medical faculty of Airlangga University. Okay, I guess we can continue for the session, even if it's 1 minute early, Doc.
Okay, there are already 23 participants. We can wait 2 minutes to get opportunity for the other participant to join this session.
All right, Doc. The session is yours to lead, Doc.
Okay, please. So there will be 5 speakers in the session, consists of Professor Charles Theo, Professor Rida Dharmajaya, Dr. Nyoman Golden, Dr. Agung Budi Sutiono, and Dr. Andi Ikhwan. The first speaker will be Professor Charles Theo, who is famous neurosurgeon from the Center for Minimal Invasive Neurosurgery, Australia. Professor Theo is a famous neurosurgeon that has concept of keyhole minimal invasive technique in neurosurgery. He is the Australian representative on the tumor section of the ACNS and CNS, and he runs a fellowship program that attracts over 600 applicants yearly and have trained many of the world leading figures in neurosurgery at distinguished centers such as Barrow Neurological Institute and Johns Hopkins, Yale, Stanford, and Harvard University. And I'm glad that I was one of his visiting fellow. Thank you so much, Charlie, for having us. Thank you. The first speaker, Professor Charles Theo, will give talk about surgery for brainstem glioma, balancing the risk and the benefit. Charlie, time is yours.
Thank you very much for that introduction. It's a great pleasure and privilege to be here with my friends from many years now from Indonesia, especially you, Dr. Susilo. Given that I've only got 15 minutes, if you don't mind, I will just get straight into the talk. So my charge today was to talk about brainstem gliomas. And after 30 years, or well, actually more, almost 40 years of experience, I can now reflect on my career and hopefully give you some indications of what I believe are the major risks and the major benefits of surgery in this very delicate area. This is our paper that we just published, looking at some of those cases, over 200 cases of brainstem gliomas in the last 17 years. And I'd just like to lump the benefits under 3 headings: curing patients, offering them a survival benefit, and improving their quality of life. The risks are even greater though. Sending a patient to their death unnecessarily is one major risk of any brainstem glioma practice. Devastating neurological sequelae from surgery. And that means operating, for example, through eloquent brainstem or inability to identify the interface between the tumor and the normal brainstem. And one point I'd like to bring up, which has really sort of become more and more obvious in my career, that surgery on the brainstem is difficult, but surgery on the midbrain is extremely high risk. And at the end of my career, I'd like to be saying to you, you really have to temper your enthusiasm when operating on the midbrain. And then, of course, I'd also like to briefly discuss the topic of biological futility. So firstly, let's talk about this. We now know them as diffuse midline gliomas, or DMGs, and we used to know them as DIPG, diffuse intrinsic pontine gliomas. They account for almost 10% of all the tumours we see in the posterior fossa in children. And unfortunately, what I've come to realise is that the diagnosis of DMG is made all too often when it isn't a DMG. And I can say that with a lot of experience, given that we get many X-rays from all around the world on my desk every week of patients with diffuse, with the label of diffuse midline gliomas. And in fact, when you look at these patients, they aren't DMGs, and they're in fact very operable cases. I'll just show you a few of these examples. The major problem is that there are no defining neuroradiological criteria. And combing the literature, and especially the radiology literature, it becomes clear that no one has actually sat down and defined the criteria by which one should diagnose a diffuse midline glioma. In fact, many of the leading authorities on this subject have still not got it right. And I can give you some glaring examples of that. This is a paper by Roger Packer, no less. talking about DIPGs. And as an example of a DMG, they use this patient who clearly has a focal glioma. You can see the margins here. There is no diffuse component to this tumor at all, and yet it's used as an example of a diffuse tumor. Here's another one. This is a review article in the American Journal of Neuroradiology. As an example of a DMG, diffuse pontine lesion, they show a picture of a tumor that's extremely focal. Here's the brainstem here. Here's the definition. There's nothing diffuse about this tumor at all. Its enhancement pattern is similar to a JPA. This is not a diffuse tumor, and yet it's used in this article as an example of a DMG. Here's another one, Radiopedia. They use this as an example of DMG, but look at the definition. There's a clear definition between tumor and brainstem. This is extremely focal, but they call it a DIPG. Here's another one, focal tumor, DIPG, and even the International Society of Pediatric Neurosurgery in their page on diffuse intrinsic pontine gliomas, they use an example of a JPA. This is a focal pontine JPA, no doubt about it. And yet it's used as an example of a diffuse pontine glioma. So even our leaders in our field of pediatric neuro-oncology still can't get it right. This is the latest review article on DIPG. These are all the leading authorities in the world. And the criteria they come up with for DMG is it has to arise from the pons, and it has to involve more than 50% of the pons. And that's the only selection criteria to call a tumor a DIPG. So if our leaders in our field can't define the criteria, the radiological criteria for this diagnosis, how are we to get it right? And believe me, we get it wrong many, many times. And here's some examples. All these tumors were sent to me as DIPG, DMG. Complete resection, complete resection, complete resection, complete, and look at that one there. There's the brainstem. The brainstem is there, the basilar artery is there. This is not a diffuse pontine glioma. This is clearly eccentric to one side. It's clearly pushed the pons over to this side, and yet this was diagnosed as a DMG. Complete resection, complete resection, complete resection. And there, look at that one, the same thing. Normal brainstem, huge tumor, basilar artery, but this has none of the criteria of a DMG, but this was called a DMG. Complete resection, they were all ependymomas. Look at these ones. This is focal. You can't get much focal than this one. That was a tuberculoma. Look at this one. Focal, xanthoma, JPA, JPA, low-grade astrocytoma, and an anaplastic astrocytoma, all completely removed. And then even this anaplastic astrocytoma is alive 12 years after surgery. So I can't say she's cured, but certainly she looked very, very good, and she's had no recurrence in 12 years. So the first risk is to get it wrong. You've got to get it right. You cannot overdiagnose DMG, because by diagnosing DMG, you are sending a patient to their death. And these patients are potentially curable. Of course, then when you diagnose that it's an operable focal brainstem tumor, you have all the risks of surgery. And that doesn't include just the approach, but also defining that interface between normal and abnormal tissue. These are some of the patients that I got wrong. Where is the safe zone here? It's very difficult to tell. The whole brainstem has been distorted. This is the floor of the fourth ventricle. I couldn't even tell where the midline is. Is this a bit of normal brainstem over the top of this tumor? And sometimes it's extremely difficult to tell what is normal, what's abnormal, and your anatomical landmarks. So this patient had a focal malignant tumor, had a complete resection, and did incredibly badly. Immediately after, he was locked in. There was no improvement in his neurological function. He couldn't even breathe. And unfortunately, we had to turn the ventilator off, and the patient succumbed after a week after surgery. Here's another patient, focal tumor. You can understand why I wanted to operate on this patient. Neurofibromatosis, focal tumor. I thought this was confined to the tectal plate. But in fact, after surgery, you can see we've got a good resection. But unfortunately, I've dug into the tegmentum of the pons. Sorry, the tegmentum of the midbrain. And once you get into the tegmentum of the midbrain, you run all the risks, such as level of consciousness. The patient was comatose for a significant period after surgery, spastic quadriparesis, bilateral ptosis. 10 years later, improved, but still not independent. And what I didn't do here clearly was define the brain tumor interface well enough. Here's another patient. This is before surgery. She only had strabismus. Otherwise, she was pretty normal. Here's the focal tumor. You can see why I wanted to take this out. Complete resection, good resection, and it looks like I've obeyed the interface, but a terrible outcome. Why? Again, because I believe that I probably went through very eloquent tissue to get to the tumor. And finally, biological futility. And what does that mean? It means that even if you identify a brainstem glioma that's focal, possibly exophytic, readily resectable, then many of these tumors are malignant, and therefore the biological aggressiveness of these tumors outweighs the benefits of surgery. And I can show you many cases. In fact, we've published our series showing focal tumors, excellent resection, good clinical outcome, but biological futility. In other words, the tumors just come straight back and you buy them very little survival time. And here's some examples. This is a focal GBM. You can see the nice demarcation here. A good resection, patient did very well, no worsening of neurological function. Here's pre-op and post-op, good outcome. But look, 2 months later, metastases all through the brain. And again, we've published our series showing that with focal brainstem gliomas that are low grade, results are excellent. The Kaplan-Meier survival curves are beautiful. You can either cure them or buy them significant extension of life. But with malignant, okay, thank you. But with malignant focal brainstem gliomas, unfortunately, the survival benefit is very minimal. Okay, let's talk about some good results and some of the good results you can expect if you pick the right patient and go for a GTR, gross total resection. This was a JPA of the midbrain, complete resection through an eyebrow approach. 20 years later, cure, no recurrence. Here's another patient. Here's the brainstem. Look at this. The brainstem is here. This is all tumor. Complete resection, good restitution of the brainstem, very stormy postoperative course, but a good result eventually. And he's even better than that now. Here's another patient. You can barely see the brainstem. Incomplete resection, but enough where we get the critical mass. This portion here was probably only about 5% of the tumor left behind. Stormy postoperative course, but an excellent outcome. Alive 9 years and died at 9 years from another problem, not even from a brain tumor. Here's another patient diagnosed as a DMG. It fulfills a lot of the criteria, but not all of them. Good resection. And this turned out to be a ventrally exophytic, focal, medullary brainstem glioma, where the pons was pushed superiorly. Complete resection. Complete resection. And again, I'd like you to look for the interface. Here it is right here. This is normal brainstem back here. And here's the interface. All of this is tumor. And again, complete radical resection through retrosigmoid and retrosigmoid incision, good outcome. And finally, I'd like to talk about the concept of improving someone's quality of life. Because people think the brainstem area is so eloquent and so high risk, they don't think of it as being an area that you can operate on and actually improve someone's neurological deficits. But if you find that interface and it is a true focal tumor, you can improve people's deficits and you can certainly keep them off steroids. We all hate steroids. There's no doubt about that. And we've all seen the devastating consequences of these children who are sometimes on steroids for the last 6 months of their lives. And the steroids have more negative effect on their quality of life than the tumor. Their appearance changes, they get diabetes, they get put on weight, they get protein wasting and muscle wasting, and their quality of life is significantly negatively impacted by the steroids alone, regardless of the tumor. These are patients with malignant brainstem tumors where we did not give them a survival benefit, but we certainly gave them a quality of life benefit. So complete resection, 4 hours after surgery, in good neurological condition. He never needed steroids until he died. Here's another one, malignant tumor, complete resection, 1 day after surgery, good neurological condition, never needed steroids. And finally, I'd like to talk about the concept of mixed, diffuse and focal tumors. And there's probably a role in surgery of the focal component of these mixed tumors. So this is the same patient, focal component, diffuse component. Here's another one, focal component, diffuse component. So I truly believe that we haven't identified this before, but there is a small category of patients who have tumors that are partially diffuse and partially focal. And I would contend that if you take out the focal component, you get good tissue diagnosis, you reduce the need for steroids, and there could be a survival benefit as well. And here's one example, diffuse component, focal component, focal component. Again, you can see the focal component. After surgery, diffuse component's just as big, but the focal component is significantly smaller. Good neurological outcome because we didn't get into the diffuse component. And again, here we go. Pre-op, post-op after surgery, we've reduced the size of the tumor by at least 70%. And then look at the result from radiotherapy, a significantly better result from radiotherapy. And I can't help but think that it's because, well, this had something to do with it, and that is reducing the tumor bulk. And again, good neurological outcome, no need for steroids. So I'd like to conclude by saying that outcomes from surgery of brainstem gliomas can be very good and can be very bad. Surgery for diffuse midline gliomas should be biopsy only if it's truly a diffuse midline glioma. Surgery for focal gliomas, regardless of the grade, should aim for a gross total resection, but you should temper your enthusiasm when you're in the or near the midbrain. There is likely a category of mixed diffuse focal tumors that may benefit from planned subtotal resection, but there is an urgent need to define the radiological features of a true DMG. What are the selection criteria? These are minimum selection criteria. The tumor must arise ventrally and extend dorsally. There must be symmetrical basilar encasement, and there must be crossing pontocerebellar fibers. They're the minimal criteria to diagnose a DMG. I'd like to give credit to Fred Epstein. He was a friend and mentor, and this was his saying, Charlie, you'll win some and lose some, but heck, without surgery, they're lost anyway. Thank you.
Of Department of Neurosurgery, Faculty of Medicine,